Welcome to the deep dive. Today we're tackling something many pet owners might worry about, or at least encounter: melanocytic tumors in dogs and cats. We're focusing specifically on the ones affecting their skin and sometimes even their toes.
Exactly. And our mission here really is to pull out the absolute must-know information from a pretty detailed veterinary guide called Canine and Feline Melanocytic Tumors.
Right.
We want to give you a clear, actionable understanding of these growths, the knowledge you need without drowning in complex medical terms. Think of it as like a shortcut to getting properly informed.
A shortcut, yeah, I like that. We want those key insights that really stick. And here's something interesting just to kick things off, something that surprised me a bit. Skin tumors are actually quite common in dogs, right? About 10% of all their skin issues.
That's right.
But in cats, it's much lower, less than 5%. That difference alone suggests there's some, really interesting comparisons we'll get into.
Definitely.
Okay, so let's unpack this. What exactly are melanocytic tumors?
Okay, so simply put, they're growths. They can be benign, meaning non-cancerous, or they can be malignant, which is cancerous.
Okay.
And they come from melanocytes. Those are the cells that produce pigment, the color in skin and fur.
The color cells, got it.
Yeah, those cells, they're mainly in the epidermis, that's the outer skin layer, but also in the nail bed.
So these color-producing cells in the skin and nails can sometimes form, growths.
Yeah.
You mentioned they can be localized but might invade. What does that look like for a pet?
Well, initially you might just see a lump, right? Even if it's benign, it can still grow and maybe press on or affect the tissues right around it.
Okay.
But the malignant ones, the cancerous forms, they're the ones we worry more about invading deeper. For instance, a tumor on a toe could actually grow into the bone.
Into the bone itself?
Yeah, the very tip of the toe bone, called the third phalanx. And even more seriously, these malignant tumors can spread. That's called metastasis.
Right, metastasis.
Yeah. They often spread first to the lymph nodes, think of them as filter stations in the body, and then potentially to the lungs or other organs.
That really highlights why, finding them early and checking them out properly is so critical. So who gets these? Are certain dogs or cats more likely to develop them?
Yeah, there are some patterns. In dogs, the average age we see these diagnosed is around 9 years old.
9 years, okay.
And what's really interesting in dogs is that certain breeds definitely seem more prone. This includes quite a few terrier breeds like Scotties, Boston Terriers, Airedales.
Oh, wow.
Schnauzers, too, Cocker and Springer Spaniels, Boxers, Irish Setters, Chow Chows, Chihuahuas, Retriever breeds, and Doberman Pinschers.
That's a pretty long list.
It is. It suggests there's definitely a genetic component for some dogs.
So if you have one of those breeds, maybe we're extra watchful for skin lumps, though really any new lump needs checking out.
Absolutely. Always.
What about cats? Is it similar?
With cats, the average age is a bit older, usually between 10 and 12 years.
Okay, a bit older.
But unlike dogs, we don't really see specific breeds that stand out as being more susceptible.
Huh. Interesting.
Yeah, it's another one of those differences between dogs and cats when it comes to these tumors. It kind of goes back to that initial point about frequency, doesn't it?
It does. So if someone listening notices something on their pet, what are the key signs? What should they be looking for that might point towards a melanocytic tumor?
Well, the most common thing is just seeing a skin mass, a lump.
Right.
How fast they grow can vary a lot. And importantly, they might be pigmented, black or brown, but sometimes they're not. They can be a melanotic.
A melanotic, meaning?
Meaning they don't have that dark pigment. They might just look like a pink or flesh-colored bump.
Ah, okay. That could be misleading.
It definitely can be. Usually it's just a single lump. Now, if the tumor is on a toe, you might notice your pet limping or seeming painful on that foot.
Okay, so lameness could be a sign too. And location. Do they tend to pop up in certain areas more often?
Yes, there are typical spots. In dogs, we see them more often on the face, the main body or trunk, the feet, and the scrotum.
Okay.
In cats, they tend to be more common on the head, the toes, the ear flaps, the pinna, and the nose.
Good to know those areas.
And it's always a good idea, when you're petting your animal, to just feel for the lymph nodes under the jaw or in front of the shoulders, behind the knees. They might feel enlarged if the tumor has started to spread.
That's a good tip.
And in really advanced cases, unfortunately, if it spreads to the lungs, you might even notice coughing or maybe some difficulty breathing.
Wow. Okay, so knowing these typical locations is helpful. Now, the big question, what causes them? What are the risk factors?
Right, the why.
Yeah.
And this is where things get, a bit frustrating from a scientific standpoint. The honest answer is we don't really know the exact risk factors right now.
Really?
Still unknown. Largely, yes. For these specific skin and digit melanocytic tumors in dogs and cats, the cause isn't pinned down. It just highlights how much more research is needed in this area.
Definitely. And it makes being aware of the signs even more crucial, doesn't it? Since we can't easily prevent them.
Exactly. Vigilance becomes key.
So let's say a vet suspects one of these tumors. How do they actually confirm it? What's the diagnostic process like?
Well, the first thing is considering other possibilities. We call it making a differential diagnosis.
Okay.
Especially for those melanotic ones, the non-pigmented ones, they can look very similar to other things like mast cell tumors, lymphoma, different kinds of sarcomas, or even carcinomas. So just looking at it isn't enough.
Right. It's not always obvious.
Not at all. And your standard blood tests, biochemistry, urine tests, they're usually normal with these tumors. So they don't often help much with the initial diagnosis itself.
Okay, so blood work might not show anything.
Often not, unless there are other issues going on. That's why we need more specific tests.
Like what? What are these specialized tests?
We can use something called immunohistochemical markers. These are special stains applied to tumor samples that react with specific proteins inside the cells. Melanoma cells, especially those tricky melanotic ones, often have particular proteins like mimentin, S100, neuron-specific enolase, HMB45, and melon A. Finding these helps us say, yes, this looks like melanoma, rather than another type of cancer.
So it's like a molecular fingerprint for the tumor.
That's a great way to put it, yeah.
Fascinating. And what about imaging? X-rays, things like that?
Oh, imaging is absolutely crucial. We need to see if the cancer has spread. Chest x-rays or thoracic radiography are standard to check the lungs for any signs of metastasis.
Right, check the lungs.
Sometimes a CT scan is even better as it can pick up smaller spots. And if the tumor is on a toe, we definitely need x-rays of that toe.
Why the toe X-ray specifically?
To see if the bone underneath is involved. Remember how we said it can invade the bone, that third phalanx?
Right, to check for bone invasion.
Exactly.
Yeah.
It's interesting, though, nail bed melanoma doesn't tend to destroy the bone quite as often as another common toe tumor, squamous cell carcinoma, so the x-ray can give us clues there too.
Good distinction. Okay, what about actually sampling the tumor? Getting cells?
Yes, that's fundamental. A fine needle aspirate, or FNA, is usually one of labor savers. That's where you use a small needle to suck out some cells, put them on a slide, and look under the microscope. That's cytology.
Okay, cytology.
We do that on the main lump and also on any nearby lymph nodes that feel enlarged. But importantly, we often recommend sampling the draining lymph nodes even if they feel normal.
Even if they feel normal. Why?
Because sometimes cancer cells can spread there microscopically before the node actually swells up, so it's a precaution.
Gotcha. Better safe than sorry.
Absolutely. And when we look at those cells, if it's a pigmented tumor, we might see those little brown granules. That's the melanin pigment.
Okay.
But remember, the melanotic ones won't have that. We might also see immune cells called melanophages that have kind of gobbled up some pigment. In the malignant tumors, the cancer cells themselves often look abnormal, maybe bigger nuclei, more variation in size. Signs are dividing quickly.
So the cells look different.
They often do. Cytology gives us a good first look, but for a definitive diagnosis and more detail, we usually need a biopsy.
A biopsy taking a piece of the tissue.
Exactly. A small piece of the tumor is surgically removed, and that tissue sample histopathology lets pathologists look at the cells in their actual structure. They assess things like the mitotic index, how fast cells are dividing pleomorphism, which is how much the cells vary in shape and size, and crucially, if the tumor is invading the surrounding tissue.
That sounds much more detailed.
It is. And again, for those non-pigmented ones, those immunohistochemical stains we talked about are often done on the biopsy tissue to confirm it's melanoma.
Okay, so it's quite a thorough process, from feeling the lump to imaging to looking at cells and tissue samples, maybe even using those special stains. It really paints a picture. Now, the big question for any owner, what happens next? What are the treatment options?
Right. The primary treatment, the main approach, is almost always surgery. Wide surgical excision.
Wide excision meaning?
Meaning the surgeon removes the tumor itself plus a good margin, a border, of apparently healthy tissue all around it. The goal is to get all the cancer cells out.
Okay, get it all. Makes sense.
If the tumor's on a toe, amputation of that toe is often the most effective way to achieve those clean margins.
Right, remove the whole toe.
Yeah. And if tests show it has spread to a nearby lymph node but hasn't gone further, like to the lungs, then surgically removing that lymph node, a lymphadenectomy, might also be part of the plan.
Okay, so surgery is the cornerstone. What if surgery isn't enough, or maybe it's not possible to remove everything.
Good question. That's when we start thinking about adjunctive therapy treatments used in addition to or instead of surgery.
Okay.
This comes up with malignant melanomas, especially if the surgeon couldn't get wide enough margins, or if the tumor is just in a really difficult spot to remove completely, or, of course, if it's already metastasized.
So what kinds of additional therapies are there?
Well, one really interesting area is immunotherapy, specifically vaccines. There's been work, for example, with a vaccine targeting an enzyme called tyrosinase. A study suggested it might have some benefit for digit melanoma in dogs. It's related to the idea behind the melanoma vaccine already approved for oral melanoma in dogs.
Wow, a vaccine. That's fascinating. Using the body's immune system.
Exactly. It's a growing field. Then there's more traditional chemotherapy.
Right. Chemo drugs. Are those effective?
They have shown some effectiveness, yes. Drugs like carboplatin, which can be used in both dogs and cats, and cisplatin, which is strictly for dogs only, never cats.
Okay, dogs only for cisplatin. Got it.
And doxorubicin. These are used. But it's really important to manage expectations. The overall response rate for melanoma with these drugs is generally pretty low, often under 30%.
Under 30%. Okay, so not a magic bullet.
Definitely not. Sometimes we also use a drug called piroxicam. It's an NSAI, an anti-inflammatory, which primarily helps with pain, but might also have some minor anti-tumor effects in certain situations. And ensuring good pain control overall, often using multiple types of pain relief, multimodal analgesia, is really vital for keeping the pet comfortable.
Comfort is key. Are there any treatments that are absolutely forbidden? You mentioned cisplatin in cats.
Yes. That's the big one. Cisplatin is highly toxic to cats, can cause fatal lung issues, so it's an absolute no-go.
Okay.
And generally, vets have to be careful when combining treatments not to use drugs that have overlapping toxicities. You don't want to double up on side effects. And of course, anyone administering chemotherapy needs to follow very strict safety protocols to protect themselves, the staff, and the patient.
Right. Safety first, always. So after treatment, say after surgery or chemo, what's the plan? What does follow-up look like?
Follow-up involves regular checkups. It's all about monitoring.
Monitoring for what?
For recurrence, the tumor coming back where it started, or for spread to the regional lymph nodes, these checkups are usually recommended every 2 to 3 months initially.
Every few months, okay.
Or sooner, of course, if the owner sees any new lumps or the pet seems unwell. We also typically recommend repeating those chest x-rays periodically to keep checking the lungs for any signs of metastasis.
So it's definitely an ongoing process of watching closely.
It really is.
Okay, finally, let's talk about the bottom line for many owners. The prognosis. What's the likely outcome after a diagnosis?
It varies quite a bit, especially between benign and malignant and between dogs and cats. In dogs, roughly 25% of melanocytic tumors on the skin turn out to be malignant.
1 in 4, okay.
But melanomas found on the toes, the foot pads, the scrotum, or where skin meets mucous membranes like the lips is, those locations are more likely to be malignant.
Ah, location matters for malignancy risk.
It does seem to. Now, if it's confirmed benign, the prognosis is excellent. Usually surgical removal is curative.
That's good news.
Yes. But for the malignant ones, either on the skin or the digit, the average survival time after diagnosis and treatment is typically around 12 months.
1 year, on average.
On average, yes. Interestingly, there's some suggestion that certain breeds might fare differently, like cutaneous melanomas and Dobermans and miniature schnauzers might tend to be less aggressive, whereas those in miniature poodles might be more often malignant. Still needs more research, but it's an interesting observation.
Those breed differences again. What about for cats?
In cats, unfortunately, a higher percentage are reported as malignant, somewhere in the range of 35% to 50%.
Higher malignancy rate in cats, then.
Generally, yes. And the survival data isn't quite as extensive as for dogs, but one study pointed to an average survival of about 4.5 months after surgery for skin or digit melanoma.
Wow, that's significantly shorter.
It can be, yes. It underscores that melanoma can be quite aggressive in cats.
So, to sort of wrap up the key points, we've seen that these melanocytic tumors have quite a range of behaviors. Surgery is the main attack plan, but really understanding the signs, the diagnostic steps, and crucially, the potential for malignancy is just so important for owners.
Absolutely.
And those differences like breed risks in dogs and the generally higher malignancy rate in cats, those are really vital takeaways.
Definitely. Hopefully this deep dive gives you, the listener, a much clearer picture and a solid foundation. It should help you feel more empowered if you ever need to discuss this with your vet regarding your own pet.
Exactly. And that leads us perfectly into our final thought for you to chew on. Given that we still don't really know why these tumors develop those unknown risk factors, what kind of research do you think would be most beneficial? Where should the focus be to help us better prevent or maybe more effectively treat these melanocytic tumors in our dogs and cats down the line?
That's a great question to ponder.
Definitely something to think about. Thanks so much for joining us for this deep dive.